So the periprosthesis for 10% of your total knee replacement. And the patella constitutes around 0.2 to 21 percentage, and that's to 99 percentage happens when there is patella is resurfaced. So always it is very challenging because that involves your extensor mechanism, like the hip, when it affects your abductor mechanism, that can compromise the functions. So there has been some other related, you can see the excessive range of motion is a contributing factor from the patient side, is a single pec patella and posterior stabilized knee are implant, from the implant side are the risk factors. If you are surgically related, your component malpositioning, especially if your femoral component is too much flexed or your AP diameter is more, not for the patient, and if there is any limb alignment can contribute to the patellar fracture. There has been various classification. The standard one is the Goldberg classification. Type 1 is undisplaced. Type 2 is either the fracture along with the extensor mechanism integrity is affected or your component is loose. Type 3 is involving the inferior pole of the patella. 3B means it is involving the ligament of patella. Type 4 is a fracture dislocation simply. And more of a practical treatment point of view, this classification is Burris classification is better. One is means stable implant and intact extensor mechanism. 2 means if it is disrupted the extensor mechanism with or without stable implant. And 3 is implant is loose, can depending upon your bone stock is good or not. So you can have an algorithm. Look at the first, the implant is stable or not. If the implant is stable, then look at the fracture is displaced or not. If the fracture is undisplaced, you have to treat it conservatively. And fracture is displaced, you have an option of a partial patelectomy or a fixation with a tension band bearing. And his implant is unstable, then look at this bone stock. If you have a good bone stock, you can go for a revision or even excision arthroplasty. But if the bone stock is less, no option. What's remaining is an excision arthroplasty or a total patelectomy. This case, you can see the intact extensor mechanism as an undisplaced fracture. You have to treat it conservatively because operative complication is high as almost 50% and chance of infection is nearly 1/5 of the patients. So this case, you can see the inferior pole of patella fracture. It can have affected the extensor mechanism. So you have to fix it. So even though you fix it properly, the chance of complication is going to be very high, as mentioned earlier, almost 50. In own cases, you can see over a period of 6 months, the fracture gave away, especially the patients rheumatoid and osteoporotic patients. So nowadays we try to avoid the hardware implants, especially the tension band bearing with the metal. You can see this is one of the technique we use to put 2 tunnel holes through the patella. One fiber tape or fiber suture go through the Charcot stitches, go into the ligament of patella, come back. Same way another into the quadriceps tendon, and you pull the either side together. That will approximate your fracture. So this is the method what we use nowadays because to avoid the hard wires and which can produce the skin healing problems. Now in this case is a poor bone stock, loose implants, no other option. You have to go for a revision arthroplasty, either you have to go for a partial patelectomy. Now we come to the tibial fractures. It's being divided into classified by Felix, and again 1, 2, 3, 4, again is A, B or C, whether the process is fixed, is the process loose, or these fractures happen intraoperatively. Now, look at the case. If the patient's implant is stable or the fracture distal to the implant, you have a very good option. You can go for either plating, especially we have a better locking compression plates available nowadays. And it's a type 3A fracture. Again, is an obese patient, he's diabetic, there was a slight open wound, and implant is look stable. Even an option of treating conservatively because it's a metaphyseal area, there is a good bone stock. If you're able to maintain the alignment and the reduction properly, you can even better treat conservatively. And this is a fracture, you can see the implant is loose, all condyle is involved, is severe valgus force, the MCL has gone, you can see the whole the fibula head is gone because of the excessive valgus force during the trauma. No other option, you have to go for a hinge or proximal tibial replacement. And this is one case patient as this is what the Mohandis are initially told. If you put a nail, if your entry point goes to posteriorly, the distal fragment can go to hyperextension and it's got malunited. Subsequently, patient again had a fall, sustained the proximal tibial fracture. Again, the implant is loose. So the algorithm goes the same. The femur, look, the implant is loose, the condyle is involved. Yes, you have to go for a revision arthroplasty or distal femur replacement. And the tibia, definitely the fracture is implant is loose, you have to go for a revision arthroplasty, even a proximal tibial replacement. So this got the distal femur replacement and proximal tibial because of proximal metaphyseal bone stock is lost, fixed with a metaphyseal sleeves and the short stumps. Thank you so much.